Okay, so this will be your last lecture for Test 3 content. This chapter will be talking about burn injuries. Obviously, with everything else that we've been talking about, our priorities stay the same. We would consider burns an acute situation, so you check on your airway, breathing, circulation, changes in LOC, work your way through test-taking strategies that way. Preventing infection and supporting nutrition are obviously Maslow pieces, and then monitoring for your comorbidities would be an evaluation piece from your ADPI. So the different types, you have thermal, chemical, and electrical, and inhalation. Obviously, thermal would be the scalding, the flash, you're coming in contact with hot injuries. Depending on the severity or the type of fire that you're in, it can be a large surface area or a small surface area. So I would be thinking to myself, if I just have it over a burn area, no matter what stage it is, over my arm, I'm not necessarily going to need the same type of care as I would need for a client with, a full body burn. Chemical burns are mostly irritants. Inhalation would be anything that gets in your airway, and then you're at risk for an obstructed airway. Electrical burns, we'll be talking about the complications associated with electrical burns. And then cold thermal injuries, I don't really care that we know a whole lot about, but just obviously if you're prolonged outside, it's like frostbite. You can have these type of thermal injuries from extreme temperatures. So let's look at smoke and inhalation injuries. Carbon monoxide is a fairly common one. You really don't know that you have carbon monoxide. It's odorless, it's colorless. If you fall asleep, and we've seen the stories in the news where people are passing away because of carbon monoxide poisoning. If for some reason you do feel that you are different in some way, you have changes in your LOC, you want to make sure that you're stepping outside, getting fresh air, not going back into that environment unless you know that the situation has been taken care of. People will say that their skin is this cherry red color and appearance. Obviously, we said the client can progressively deteriorate because it is odorless, colorless, and can occur in the absence of no burns. So it would be considered an inhalation type of injury, obviously. If you're in a large fire, if you're close to a large fire, like a campfire, house fire, whatever, you can still end up with an inhalation injury. So no matter what the client's SpO2 says, it is not a good indicator of care. You're still going to try to treat this client with 100% humidified oxygen. Again, because they are at increased risk of airway occlusion. So if we do have airway obstruction occlusion, it is a true medical emergency. Things we can look for are, facial burns, their face is beet red, they have singed nose hairs or eyebrows, they have this hoarseness or this painful swallowing. It's letting me know that airway is trying to occlude on us. We could see pulmonary edema develop within 12 to 24 hours. It could be sooner in that time frame, but generally speaking, based upon the severity of the wound, that's the time frames that you're looking at. So that's why we're still giving this supplemental oxygen, because we don't know the extent of this burn injury until we can monitor them for a while. And then obviously, because of the pulmonary edema, this can quickly turn into acute respiratory distress. For clients with electrical burns, I would say the priority here is knowing the extent of the burn, the entry and exit point, and then noting that the client is at risk for dysrhythmias. We can have a lot of muscle breakdown. They can end up with rhabdomyolysis, myeloglobinuria, things that are going to really cause the kidneys a lot of damage. So make sure that we are assessing this client thoroughly, entry, exit point. Make sure that they're going to be on telemetry while they're with us. That's the whole electrical system of the heart. So you have an outside source of electricity, and now it's going to play a role into how well you're healing or not healing, or your increased risk for dysrhythmias. So if you're looking at this client and he has an electrical burn, you're looking at this flow of electricity. It's going to follow the path of least resistance. So here I would have an entry wound, here I would have an exit wound. You can see that if I have high temperature of electricity traveling through the body, all these other organs are at risk for failure or some sort of damage. This is a really severe type of thing to happen because that electricity is not forgiving. Don't really care that you know about the classification systems. There's going to be a picture next. We'll talk a little bit more about it. It's just to help you guys understand or visualize. Once I get into this deep, full thickness, you're starting to see where you're going to have that muscle breakdown. It's beyond the actual muscle itself and into the fascia versus a full thickness where it's just into the muscle itself a little bit. And so your treatment is going to be based upon the burn staging, but it's also, more importantly, probably going to be based upon how much of your body is burned. If you guys look at the burn table and it talks about the rules of 9, and you got a client, like I said, who's burned on the arms and it's 9% a burn, that's going to be less aggressive than if the client had this 18 plus 18 because of the front and back of the thoracic cavity, plus 9 for the arm. So you can see where the care is going to be different. For this client, I probably don't need a whole lot of fluid resuscitation, whereas this client, with this thoracic burn, it will definitely need some sort of fluid resuscitation. So other things to look at when determining the severity of a burn is obviously if it's facial, circumferential, which would indicate to us that maybe they're in need of an eschorotomy. If they have burns to the hands, feet, eyes, or the joints, or the perineum, which would increase their risk for infection. So eschorotomy, basically what we're trying to do there is provide your body a way of avoiding a compartment type syndrome. So if all of a sudden you see lower extremity edema, you have decreased or diminished peripheral pulses, you're going to go through here and you're going to make this surgical incision, and that's going to allow that fluid accumulation to still happen without pressing down on everything in your vasculature system. Phases of burn management, the biggest one for us is going to be this emergent phase, and that starts from the point of onset of the burn till we start making fluids. So big nursing priority would be I's and O's, obviously fluids, and above those would be airway, breathing, circulation. Your acute phase is when you begin making urine. And the rehabilitative phase is they've moved beyond here and now we're ready to discharge. So during the emergent phase, some things to think about. Obviously secure your airway, breathing, circulation, pain control, and prevention of infection would be Maslow's, and then some emotional support, Maslow's and nursing process. So we talked about when the emergent phase begins. So onset to the production of urine, it can usually be 24 to 48 hours. The greatest risk here that I'm looking for is hypovolemic shock. This is going to be tricky for us because they're at risk for hypovolemic shock, but we're also going to increase their fluids, in which case we can also give colloid solutions. So LR, volume expander, helps pull fluid back into the vasculature, albumin, things like that. So I go from this hypovolemic state now to this hypervolemic state. So clients at risk initially for hyponatremia and hyperkalemia. Obviously, if you have a shift of the fluid from the vasculature to the interstitial spaces, that salt's going to go where fluid goes. Hyperkalemia is typically associated because of the breakdown of your blood cells, so potassium being the major intracellular electrolyte, and once it gets out of that cell, it's into your serum. So obviously you would be at risk for changes in LOC, would be a big one for sodium, and then dysrhythmias for potassium. We have issues with inflammation and healing. So we have that whole inflammatory process happens. You're going to see shifts in your WBCs. Priorities would be making sure the client is getting their proper wound care. Make sure that it's sterile for those big, large surface areas, deep, full thickness or full thickness burns. Monitoring for any inhalation injuries. Remember, we said signs and symptoms don't necessarily have to appear right away. You're still going to treat them with 100% oxygen. And then if you do have this shifting of fluid from the vascular to the interstitial spaces, you're at risk for that thick blood, that hyperviscous blood, which would increase their risk for clots, PEs, strokes, all those bad things that we would associate with coagulopathies. You have decreased blood flow to the kidneys, so that's another big reason why we're going to monitor eyes and nose. We're going to be hitting them with a lot of fluid. We'll talk about the Parkland formula here in a little bit, and your rates on your fluid intake are going to be really high, so you want to make sure that your kidneys are able to handle that amount of volume. So checking their BUN and creatinine would be a good option for us before we initiated like too much fluids. Again, airway management, probably early endotracheal intubation depending on the severity of the injury. Eschorotomies, bronchoscopies. If there is no inhalation injury, because we want to make sure that we're not causing further agitation or irritation. And then obviously we're going to treat that with humidified oxygen. So we say after airway breathing circulation, the priority is fluid resuscitation. So you always talk about your starting 2 large IVs using this Parkland Baxter formula that we'll talk about next, making sure that you're using fluids. And for our purposes, it will always be LR or your colloid solutions. Something like albumin can also be used in conjunction with LR to help bring fluid back into the vascular compartment. So the Parkland formula is pretty straightforward. If you ever got it like on a test question, I would tell you, the healthcare provider has prescribed LR at 2 milliliters per kilogram times the total body surface area of the wound. So you don't have to do a lot of guessing there. That information would be given to you. So the example would be you have a client who weighs 70 kilograms. So the healthcare provider has ordered 4 cc's to a 70 kilogram client. So 4 times 70. And then they have a burn area that is 50%. So times 50. So in the first 24 hours of their care, this client is going to receive 14 liters of fluid. So we're going to give half of that, so 7,000 milliliters in the first 8 hours. So you're going to divide your day into threes, 8, 8, and 8, so 7,000. And then obviously you have 7,000 left, so you're going to divide that between these 2 remaining hours. So you end up with 3,500 and 3,500. And then you could take it one step further and you could say, okay, what is the flow rate on the IV fluids in the first 8 hours? How much volume would the client be getting in the first 4 hours following a wound? So just divide that by 2 and you end up with like 3,500. So it's pretty self-explanatory and is a little simpler than I think most people make it out to be. Again, it's just a practice of making sure you remember the 2 times kgs times BSA. Obviously, it's going to be very painful. So watch for your drug therapies, um, your opioid analgesics. Make sure you have your Narcan available. A lot of scrubbing with wound care. And it's typically, depending on the severity of the wound, it's not going to be the actual wound itself that hurts. It's going to be the areas that didn't get as bad as the rest of the area. So I kind of think of it like a canyon. Down here, if the burn injury is all the way down here, you've kind of destroyed all your nerve endings. So it's always like this kind of area that is going to be really painful, really sensitive. And this area that is going to be at increased risk for infection. So make sure we're cleaning our clients when we're doing those kind of wound care dressings. Make sure we're using sterile gloves because it is just an open source of infection. Tetanus immunization is given to all clients with a burn. And a drug that we typically see used is something like silver-sulfidine. Initially, that fluid replacement takes priority over the nutritional needs. That doesn't last very long. Remember, as soon as we're moving from the emergent to the acute phases, that nutrition is going to be really important for us. But we want to make sure that we're also monitoring for like a paralytic ileus. Make sure that gut is actually moving like it's supposed to when we're giving them tube feedings or however they're taking their oral. Probably not oral, however they're taking their nutritional intake. So making sure you're looking at the adequacy of fluid resuscitation. Make sure you monitor your urine output and notice we're not using that 30 milliliters per hour. It is an exact rule for your client with an electrical burn. And again, think of those rhabdomyolysis, the hemoglobinuria, myeloglobinuria issues. Those big protein molecules, big molecules in general getting caught up into the kidneys and causing acute kidney injury. Make sure that we're monitoring or doing things to promote perfusion and monitor for shock. These clients are going to be in a hypermetabolic state, and that's why we said fluid is a priority, but nutrition is also very important for these guys, right? Because they are using 50 to 100% above their normal baseline. So as you can imagine, this would be like a high protein, high calorie type of tube feeding that we would want to initiate on these really bad burn clients. So once you move beyond the whole airway, breathing, circulation, nutrition, wound care, we're going to start into this acute phase. So the acute phase begins with the mobilization of urine. So initially you're going to have large quantities of pale urine, and hopefully then you'll get rid of all the bad stuff, so you may end up with that really dark black, red urine, and then hopefully once we get all that flushed out of your system, you'll start seeing normal urine. This phase is going to last, again, until we actually go through the process of covering that burned area with skin grafts or however the healthcare provider is going to provide the end outcome. These clients, again, they're still at risk for electrolyte imbalances. We talk about hypernatremia, hyperkalemia again. Just so really important. If you start to see any signs and symptoms of either one of these, again, we talked about the changes in LOC, we talked about the dysrhythmias, changes in the I's and O's, that you're making sure that we're getting the appropriate diagnostics, CBCs, CMPs, WBCs, things like that. Hyperkalemia, we've talked about, obviously, it's a risk for cardiac dysrhythmia. As you can see, you can see ECG changes and muscle weakness. Hypokalemia, this can be because of lengthy hydrotherapy. That's a little deep for us, but basically we're going in and we're submerging them in a tub, and because of the destruction of the skin, that fluid is going to easily transfer from that pool into the client. It can also happen if we have vomiting or diarrhea with the client, and obviously if they have diarrhea and the wound is really bad, they're going to be increased risk for infection as well. Another reason would be prolonged GI suction. Um, so just during the acute phase, right, we're going to do our observations, we're going to do our assessments, cleaning with debridement, and of course your sterile dressing reapplications. I won't be asking you anything about hydrothub therapy, cart shower, shower bed, anything like that. Just make sure that you're going under using proper wound care guidelines for making sure we're not promoting or increasing the risk for infection. These folks are going to go under multiple dressing changes. So again, it might be painful. So we're thinking Maslow's for pain control. You have the sterile gauze dressings laid over that topical antibiotic. And that's going to be so different between individual institutions. They can be changed from 1 to 3 times every 12 hours to once every 3 days, depending on, again, where we're at in that whole healing process. And then to move out of that acute phase, we're going to start thinking about grafts. I'm not going to ask you anything about grafts, but you should know, just like for NCLEX, the different types of autografts that we can use. Ourselves, we can use cadavers, we can use animals, the xenograft type of things. So really not a whole lot here for me, because that will move you straight into the rehabilitative phase. So we are basically done with the EAR. So once they have that skin graft, you're going to do things like teach them about home care, make sure that they're not exposing that graft to direct sunlight. It's going to be easy to damage that graft area. Make sure that we're teaching them about permanent graft coverings. Pain medication, again, would be another teaching aspect. And then teach them signs and symptoms of infection. So that is really it for burns. Please, please, please just stay with my PowerPoint for burns. If you need a refresher on that, just read the information that I specifically mentioned in your lesson plan and those pages. But keep it simple, basic nursing.